Good morning, everyone. Welcome to this British Heart Valve Society Aortic meeting. Thank you all very much for joining us. We've got 8 fantastic abstracts and presentations today. We're going to have 5 minutes for each presentation and then a 3-minute Q&A after each session. So please put any comments, questions for the audience into the Q&A. And just a reminder for panel members and speakers, if you can mute yourselves whilst we're presenting. We will leave the screen and invite our first speaker up, who is John Mcdonald, and he's going to present initial experience of a Zaki procedure in young adult and paediatric population. Welcome.
Hello, my name is John Mcdonald. I'm a fourth-year medical student. I undertook a study assessing the initial experience of the Zaki procedure as part of my BSc dissertation last year, and I've been invited to present the findings today. Professor Mark Danton was my supervisor and hopefully will be available to answer any technical questions you may have. The Zaki procedure was first introduced in 2007 and involves 3-leaflet neovalve construction using autologous pericardium. It acts as an alternative to the Ross procedure. The procedure carries several theoretical advantages linked to its preservation of native annulus and sinus of Valsalva. This preserves physiological blood flow and reduces the risk of patient-valve mismatch. The procedure itself involves intercommissural distance measurement using a specific sizer, which maps to a specific template, which is then used to create 3 neoleaflets. These are made from autologous pericardium, which is fixed in glutaraldehyde and is then implanted. The main concern with the Zaki lies with its durability, due to its complex nature, long suture lines, and risk of leaflet degeneration. The Zaki's original 850 patient elderly cohort reported a 5% reintervention and a 7% moderate AI rate at 10 years. Additionally, the Kaplan-Meier plot shown is from a study by Wiggins in 2019 in an adolescent population, which reports a 25% moderate AI or reintervention rate at 4 years. So, moving on to our Glasgow study now. Our study aimed to determine the short-term clinical and hemodynamic outcomes of the Zaki procedure. It was a retrospective cross-sectional analysis of Zaki patients, giving a cohort of 22 with a mean age of 29. It was a unique study in that it focused on the young adult population, unlike the current studies which focus on either elderly groups or paediatric groups. The demographic data and patient age distribution are as shown. The median follow-up was 31 months and the longest over 4 years. 18% of patients had undergone previous aortic valve surgery, and our group was predominantly AS or mixed pathology. The intraoperative findings are shown on the left here. These are long operations, and some of this may be due to a learning curve aspect to the study. However, we also included redo operations and additional procedures. Autologous pericardium was used in all first-time procedures, and a second run of bypass was required to re-intervene on the aortic valve in 4 patients. The post-operative clinical outcomes are shown on the right. There was no in-hospital mortality, 1 perioperative CVA, and 1 prolonged ITU stay requiring tracheostomy. There have been 2 late re-interventions for valve failure, both due to suture line dehiscence. There have been no episodes of thromboembolism, bleeding, or endocarditis. Here we see box plots and actual data points of peak valve gradient for all patients at pre-op shown as 0, early post-op in hospital shown as 1, and then 2, 3, and 4 years post-op. Perhaps the most key findings, these illustrate the excellent reduction in gradient found, which also remains consistent across the course of the study. This suggests that low gradients act as over follow-up act as an advantage to the procedure. These graphs show the relationship between the Zaki and patient size. Although we have demonstrated some moderate correlations between patient size and gradient, there is no strong evidence of patient valve mismatch and the gradients are low. However, further study is needed to clarify this issue. Here we see a stacked bar plot which shows the progression of AI after the Zaki. Initially, we see good competence with over 90% of patients with mild or less AI. However, as can be seen from the increasing proportion of patients with more significant AI, there is an increase with AI over time. This rises such that at 4 years around 20% have developed moderate AI. and 2 patients required reoperation, as I mentioned. This is the main concern with the Yazaki and requires close follow-up. In conclusion, this study has assessed the preliminary results of the Yazaki procedure in a unique young adult cohort. It demonstrated good gradient resolution, which was consistent over time and might be an advantage over other options. In addition, the Yazaki allowed root enlargement and preserved the pulmonary valve, reserving the Ross option for later. However, our study has shown significant AI progression, which may be related to technical issues or leaflet material. We propose the Yazaki can be used with caution as an alternative to the Ross in children and young adults, especially where there's an advantage or preference to avoid anticoagulation. They should be fully informed of expected outcomes and require regular echo surveillance. We now have 30 patients with the Yazaki and our work will continue. Thank you for listening. I believe we'll now open up for some questions.
Thanks for your presentation. If you want to join us on stage, and Azar, could I ask that you leave the stage for the time being by pressing the red button, and we'll come to you after your presentation.
Okay, thank you.
Thank you. And again, a reminder, please pop your questions on Slido so that we can ask our presenters as we move through the session. Omar, I'm going to come to you, as I know this is an area that you were involved in. Do you have a question for John?
Can you hear me? Oh.
Okay, we're struggling a little bit with Omar. So John, my question, you mentioned right at the outset, apologies everyone for the technical difficulties, but you mentioned right at the outset that the possible real advantage with this may be that long-term hemodynamic, long-term good hemodynamic results and durability. Do you think you managed to answer that question in your study?
I think to a certain extent we did manage to answer sort of the initial aspect of that question. In particular, the Yazaki showed really good post-operative gradients related to the aortic stenosis up to the 4-year period we had follow up to, and the gradients remained low up till this period. So that suggests that up to that period we have a valve that has good hemodynamic capability. However, as I also showed, we do have a significant number of patients who have developed post-operative aortic regurgitation, and as such, that could be a potential issue as related to the durability of the valve. So I think we have the initial answer to that question. However, further evidence is definitely needed to more fully answer that question.
John, can I quickly ask you what was the mean gradient? You've showed it, but it wasn't clear from your chart. What was the mean gradient immediately post-op and say at 1 and 2 years?
I'm not sure the values off the top of my head, but the gradients did remain fairly low, and we looked at both mean and the peak gradients of the valve, and both of those remained fairly low. But I can look further into the.
I think from your chart, they're not that low. Your grade, I couldn't really make whether it was the mean or peaks, but they're not low. I mean, if you look at the Ozaki, the actual Ozaki paper, he had peak gradients of 19 plus or minus 10 at discharge, and yes, these did come down to in the 15 range, but these gradients are quite high compared to the Ross procedure and compared to valve repairs.
Okay. Yeah, absolutely. It's something that I'm only starting to understand the significance of just how significant sort of gradient differences. And yeah, it's definitely something that needs further looking into with the Ozaki as to whether that is a potential advantage to the procedure.
Thank you.
I know we want to move on shortly, but if you could just next slide over those couple of questions and make sure our audience is included in this conversation. I know it's hard when we can't see you. Okay, I think there's some technical difficulties as well. So we will move on to the next presentation. Thank you very much, John. Our next presentation is the other end of the patient population, choice of valve in patients over 75 years, a comparison between conventional aortic valves and rapid deployment valves. And this is presented by Nada Mowad.
Good afternoon, ladies and gentlemen. Thank you very much for your time and attention, and thank you to the organizing committee for giving us a chance to present this presentation titled The Choice of Valve in Patients Older than 75 years of age, a comparison between conventional aortic valve versus rapidly deployed valves in a single center experience. That's from the cardiothoracic surgery unit in the Royal Victoria Hospital in Belfast. As we're all aware, with the most recent 2017 European guidelines for management of valvular heart disease, the choice of intervention for aortic stenosis is left in the hands of the heart team. And a patient being older than 75 years of age, TAVI was favored over surgical aortic valve as a treatment option. And that's echoed again in the 2020 American guidelines, where the choice of intervention for patients aged 65 to 80 can go either ways, either TAVI or surgical aortic valve replacements. And being older than 80 years of age, TAVI is the most favorable option. However, we're still seeing the majority of these patients being offered surgical valve intervention in the UK. With the emerging technology of rapidly deployed valves, Belfast was one of the earliest centers to adopt this technology back in 2015. With the first Percival valve implanted in December 2015, shortly followed by the Edwards Intuitive valve in June 2016. So we looked into our database for patients who were older than 75 years of age at the time of their procedure, who underwent surgical aortic valve replacement plus or minus any other concomitant procedure in the period between January 2014 and January 2020. We excluded patients who had incomplete data or were lost, the follow-up was lost, and the patients who had mechanical aortic valves. 686 patients were identified in total, of which 495 patients received a conventional sutured valve, and 102 received rapidly deployed valve. Comparing the preoperative characteristics, both groups were more or less well matched in terms of Euroscore, left ventricular function, but more female patients were in the rapidly deployed deployment group, and a higher percentage of the patients were actually over 80 in the sutured valve group. Looking into the intraoperative findings, as expected, both the bypass time and the cross-clamp time were significantly shorter in the rapidly deployment group. And looking into the post-operative findings, there was no significant difference in intensive care stay or hospital stay between both groups. However, significantly more patients required permanent pacemaker implantation in the first 30 days after surgery in the rapid deployment group. Post-operative echoes showed comparable pressure gradients, both peak and mean, and also valve area when it was measured. Looking into the 30-day mortality, more or less around 2% in both groups, and in a 1-year survival around 95% for both groups as well. Having plotted the Kaplan-Meier curves for both interventions, they are more or less exactly the same in terms of survival probability. We understand there are limitations to our study, as those patients were not randomized to either types of treatment, and also the patient groups were not propensity matched. But we feel that it's safe to say that rapid deployment valves have shown comparable early and medium-term outcomes and valve dynamics. They significantly shortened the operative time and cross-clamp period, and they also carry an increased risk of need for permanent pacemaker implantation post-operatively. Thank you very much for the attention, and looking forward to your questions. Thank you.
Thank you very much. That was a very interesting presentation. Just looking at the data, you only mentioned a severe paravalvular leak. I think more often you see a moderate, and that's the interesting group, isn't it? Certainly in TAVI, the moderate paravalvular leak don't do so well in terms of morbidity, mortality, and symptoms. Did you look at moderate leak as well?
We plotted all of the. I mean, this is for the sake of this presentation, we only mentioned the severe paravalvular leak. However, moderate and mild paravalvular leak, we also looked in them, but they were also, again, of not much significance. I think it was around less than 1% of both groups had moderate paravalvular leak. And also, as you can see, the outcomes were not different between both groups either ways.
Nader, thank you for your presentation. We've got a question, a very good question from the audience about how do you choose your patients for the rapid deployment valve?
So when the first technology was introduced, that we had certain guidelines amongst the surgeons which patients have a rapidly deployment valve due to cost issues. So the characteristics were patients above 80 who have a valve area around 19 or less surgeons are allowed to choose rapidly deployed valve. Above 80 with a poor LV function or moderate LV function, or a patient who's above 75 who have both poor LV and a small root. Then after that, it was a patient who having aortic valve disease plus CAPG ×2 or greater, or a triple valve procedure, aortic mitral engrafts or aortic tricuspid engrafts. However, these characteristics were all of these recommendations were lifted after 2 years, where surgeons would choose the type of valve at their own discretion after having proven the feasibility and the benefits of rapidly deployed valves. So currently, the surgeon chooses whatever they want to.
So you say that the benefit. I completely understand the shorter cross clamp and bypass times, but how did this interpret into actual hard and solid clinical results? Your mortality rates are the same, but in fact you've got a higher pacemaker rate in the rapid deployment valve. So you're saving time in the operation to give them a pacemaker afterwards. So
I think it's a very, 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 very valid point. Yes, we could not prove that rapidly deployed valves have actually transformed surgery. But also, if we think about it, I understand Euroscore were the same, but Euroscore is not the only. The patients that received rapidly deployment valves were usually the sicker patient or are having longer procedures. So it's almost impossible to know how these patients would have fared if they have had a longer bypass or cross clamp time.
Okay, we've got a question from the audience from Uday Trivedi. Were you able to look at valve implantation depth into the LVOT?
No, it's not something that we were able to look into. I suppose if we were looking into doing this prospectively, that would have been something that we'd be looking into. But this was more of we were dealing with the data that was stored on our systems with post-operative TOE reports and actual outpatient echo reports. So I'm afraid we haven't looked into the depth of the valve implantation. However, we follow the manufacturer's guidelines in terms of levels of placement. As in for the Percival valve, we will place 3 stitches at the nadir of the valve to guide the Percival valve. And for Intuity, we would place 3 stitches that stay in and get tight. So we were following the manufacturer guidelines, but we have not measured it.
Great. Thank you very much.
Thank you.
Okay, so I think in the interest of time, we'll move on to our next presentation. We're going to Subrasina next for aortic valve neocuspidization, Ozaki procedure in adults, first UK experience.
Hello, my name is Subrasina and I'm a cardiac surgical trainee at the Southwest Deanery. I'd like to thank the Society for allowing us to present the results of the UK experience with the Ozaki procedure using autologous pericardium in adult patients. I'd like to thank my co-authors for their contributions to this work. We have no conflicts of interest to declare. We'd like to present the results of the operation performed at 2 centres, namely Bristol and Coventry, over a 2-year period between 2018 and 2020. During this period, 3 surgeons, for whom 2 are dedicated adult surgeons and 1 is a paediatric/ACHD consultant, performed these procedures on 55 patients. The mean age is lower than that for your average AVR, with which that being of 58 years. Around 60% of patients were male, and just under 20% of patients had some degree of left ventricular impairment. Just over half our patients had bicuspid aortic valves, with the predominant pathology being aortic stenosis, followed by endocarditis, and 4 out of 10 patients had concomitant procedures, including 20% of whom had ascending aortic replacements. We found that in these 55 cases, there were no intraoperative conversions nor complications. And we found that freedom from death, structural valve degeneration, reintervention, and endocarditis was at 92.5% at 2 years. Most patients had nil or trivial aortic insufficiency with very low peak transvalvular gradients, as you can see here. We also noted a marked improvement in the NYHA class of the patients post-operatively. During the follow-up period, of which the mean follow-up was 13 months, we had 1 patient that had a TIA and made a full recovery. We had 2 patients that returned within a year with endocarditis. Of note, one of these was an ongoing intravenous drug user that subsequently developed a complex aortic root aneurysm and a multi-drug resistant organism. And we also had 1 patient that died in her 80s from respiratory failure and sepsis. As noted in previous studies, the cross-clamp times were higher than those for your typical isolated aortic valve replacements, although there was marked variability between surgeons. We'd also like to make note of the fact that 3 of these 55 cases were for aortomitral endocarditis. The first of these cases is presented here on the left. The patient had a free-flowing aortic insufficiency, as well as an anterior mitral valve leaflet lesion. We approached the anterior mitral valve leaflet via the aortotomy and excised the lesion. We then replaced this with a bovine pericardial patch and then used glutaraldehyde-treated autologous pericardium to perform the Ozaki procedure on top of this. At 1 year of follow-up, we found that the patient was clinically well, and this is his transthoracic echocardiogram. It shows that the aortic valve continues to function well with no aortic insufficiency. The mitral valve is competent and there's good biventricular function. We also performed a meta-analysis comparing the AV Neo procedure with the established biological valve substitutes, namely the trifecta, Magna-Ease, Freedom Slowlo, Freestyle, MitraFlow, and the Ross procedure. We accepted papers that had over 500 patients and had at least 2 years worth of follow-up. with the exception of the Freedom Solo and the Ross procedure, in which we accepted papers that had over 200 patients and at least 2 years follow-up. We found that on comparison, the Ozaki performed similarly to most other biological valve substitutes when looking at structural valve degeneration, endocarditis, and reintervention. This was with the exception of the Magna Ease valve, which showed a almost significant reduced incidence of structural valve degeneration and endocarditis, and therefore resulting in a significant reduction in the degree of reintervention. We then reperformed the analysis with the Magna Ease valve as the comparative valve and found that it outperformed all other biological valve substitutes. The full results of our meta-analysis and our Preoperative details can be found in our paper in the European Journal. So we conclude that the AV-NEO or the Ozaki procedure is a safe strategy with acceptable midterm outcomes that are comparable to most biological valve substitutes. It had excellent hemodynamic profile, but we accept that the long-term durability is still uncertain and ongoing follow-up and investigation of these patients with imaging and clinical review is required. And we feel that over time, not only durability, but also the defined target population will be identified. At present, we feel this is indicated in the non-elderly, those with a high BMI or a small aortic root, those with endocarditis without annular involvement, and those with bicuspid or tricuspid aortic valves. Thank you very much.
Thank you very much for this presentation, Shubhra, and the good collaboration between two units. I've got a couple of questions. I really like your final point about the patient selection, you know, about the endocarditis, small aortic roots. Like, as you said, I have my fears about the long-term durability of the Ozaki procedure, but I understand its advantages and the fact that you haven't got a stent, the fact that it's a standardized new cuspidization, and the fact that you're using more or less natural tissues. So I think maybe in the as a short-term fix for endocarditis patients with small roots, where you don't want to exhaust, you don't want to go through a Ross procedure in someone who's got active endocarditis, they're on vasopressin or NORAD. I think it might have a very good place. I do have a question about when you looked at structural valve degeneration compared to the other valves, and you included the Ross. What was your follow-up period? Because I think if you look at Ozaki's series, you'll find that his durability is definitely inferior to the Ross at 53 months. So what was the period looked into?
So for the meta-analysis, well, first of all, our mean follow-up time was around about a year at the time of publication. We've now got a few patients up to 3 years, and obviously we'll be looking to report on the outcomes as we progressively follow them up. With the meta-analysis, we looked at papers that had at least 2 years worth of follow-up, and for the Ross had at least a registry of 200 plus patients. We did a mean weighted follow-up to try and average out the follow-up times, and for the Ross it was around about 9 years. So the follow-up was longer, and so obviously there's more time for the degeneration of the autograft during that period of time. And I think this is an accepted outcome with any Ozaki paper at the moment, is unless we've got follow-ups at 5 and 10 years, you can't solidly say that it's an alternative to these valves that are available at the moment or available off the shelf. But as you say, I think it has to be noted that even in Ozaki series as well as ours, the main reasons people came back was endocarditis. Now, whether I have to sort of look at the details of that and see how many of those were recurrences of endocarditis in his original series versus new onset endocarditis. But the rates themselves was fairly comparative with the other valves when we had a look at the meta-analysis. But in the short term, yes, or even in the longer term, if we can avoid prosthetic material in an endocarditic patient, it may be useful. But yes, sorry.
Mr. Briff has got a question.
Yeah. Hi, thanks. That was an excellent presentation. It's good to see, as Omar mentioned, output from two units working together. Yeah, I have an issue. I think that there is a problem with endocarditis with this operation. And as Omar says, now as you pointed out, that Ozaki himself had quite, and most of those cases weren't endocarditis, they were new onset endocarditis. And it is possible that it's because you have this piece of material that's lying open to the atmosphere for a prolonged period of time. Now, whether prolonged post-op antibiotics will deal with it. The other issue is durability of all tissue valves is dependent on the material. And most people's pericardium, I mean, if you look at the companies, when they use bovine pericardium, they will slaughter loads and loads of animals before they find the perfect pericardium to use. And most human pericardium is imperfect. People have, episodes of pericarditis and all the rest of it. And that, to me, is a problem, I think, with this operation. The concept is fantastic. The ability, you can remove cusps. Because when we do an AVR, we just remove cusps and put cusps on a stent and material. This is remove cusps and you put back cusps. So the concept is good, but I'm not so sure the material that we use is the best that we could.
So I think that's fair. I think we definitely need more patients and more follow-up to figure out the definitive rate of endocarditis, because there will be a rate with any valve implantation. I think the second thing to say is that we've slightly changed the way when we do it. So there was a separate table and you sort of created the valve there, whereas now we try and keep everything as close to the chest and covered at least with a swab or something like that, just to try and prevent any contamination in the area. But obviously it may not be the same as manufacturing it in a sterile lab environment as you would do for any of the off-the-shelf valves. But yes, I think it's something we have to keep an eye on.
Thank you.
Great, thank you. So one last question from the audience. Do we have time, Jill? Do you think the key problem to the long term of the Ozaki in the non-infected setting, is it aortic stenosis or aortic regurgitation?
So I think probably stenosis, based on when previous series based on pericardial tissue being used and the calcification that could result from that. So again, we've adjusted our technique slightly to use lower fixation times in the glutaraldehyde to hopefully try and prevent some of that. And if there is regurgitation, that could be partially due to calcification, but also the learning curve with initially implanting it, because we sometimes see very mild AR at the commissures, which is where you need a little bit of surgical nuance. And as we've done more cases, we found that rate has reduced quite a lot.
Yeah, you always get this mild commissural AR, even with valve repairs and Ross's. But I think I'd proceed with caution there, because in Ozaki's series, he had a 7% significant AR in 53 months. So maybe the calcification also causes like a type 3 L-Cori restriction. Thanks.
Thank you.
Yeah, thank you very much. We're going to move on next to sutureless aortic valve versus stented aortic valve performed via mini stenotomy, a single surgeon experience, and that's with Azza Hussain.
Good afternoon, ladies and gentlemen. I am Sameh Mohammed, one of the cardiothoracic registrar at King's College Hospital. It is an honor to join such a fruitful gathering. Today, I'm going to present sutureless aortic valve vs stented aortic valve performed via mini sternotomy, a single surgeon experience. Perceval valve is a sutureless aortic valve, which is a collapsible stent-mounted aortic valve by prosthesis that can be placed in a sutureless fashion. Many studies showed that the Perceval valve facilitated minimally invasive surgery with less cardiopulmonary bypass time and aortic cross-clamp time, which make it appropriate treatment option for a high-risk operable patient and a variable alternative to the TAVI option. Many studies also show that rapid deployment valve can be considered the first-line treatment option for patients with several comorbidities, advanced age, a small calcified aortic valve, porcine aorta, and previously implanted aortic homografts. Santarpino and his colleagues published a study in 2014 comparing two groups of patients with a high Euroscore needed aortic valve intervention. Each group consists of 122 patients. One group underwent sutureless aortic valve and the other underwent TAVI. They concluded that a rapid deployment of valve through mini sternotomy may be the first-line treatment in the high-risk patient, and they can come in the gray zone between the TAVI option and the conventional option. Our study is a retrospective study done in a one unit by a single surgeon performing isolated sutureless Perceval valve via mini sternotomy and compared it with Edward Bremont Magnese bioprosthetic valve. And we are going to compare between the cross-clamp and bypass time, stroke rate, use of permanent pacemaker, paravalvular leakage post-operative. Our study included 138 patients, and the data was collected in two groups. One group is for the Perceval valve, which was 72 patients, and the other group, which was Edward Magnese valve, which was 66 patients. Hemodynamic parameters and the clinical outcomes were monitored until the discharge of the patient to analyze the early results of the two groups. Here is a slide showing the preoperative demographic data for the post growth, and we can find out that the mean age for the Perceval valve was reaching up to 74-year-old, while the mean age for the Edward Magnese valve was 65-year-old. Our results showed that the cardiopulmonary bypass and aortic cross-clamp times needed for aortic valve replacement with sutureless were significantly shorter than that needed for Edward Bremont Magnese valve. If we can go through the numbers, the main cross-clamp time, the main cardiopulmonary bypass time for the sutureless aortic valve was 69 compared to 91 for Bremont Magnese with p-value 0.015, while the mean aortic cross-clamp for the sutureless aortic valve 47, and the opposite side for the Bremont Magnese was 71, with p-value of 0.005. The permanent pacemaker implantation was required in 3 patients for the sutureless aortic valve and just 2 patients for the Bremont Magnese. And the transvalvular gradient between the post group doesn't show that much difference, but a little bit less for the sutureless aortic valve. And it was nearly the same mean valve size. There was only mild paravalvular leak in both groups, 4 patients in sutureless aortic valve and 3 patients in Edward Bremont Magnese. No stroke patient in sutureless valve, while 2 stroke patients in Edward Bremont Magnese, and in both groups there were no hospital mortality. Here's the slides for the results showing that there is a significant difference between the cardiopulmonary bypass time and the aortic cross-clamp time in sutureless aortic valve in compared with Bremont Magnese. And to sum this up, our outcomes are in line with the current literature for the Perceval valve. Sutureless bioprosthesis seems to be represent a good alternative with short clamp and bypass time to conventional stented bioprosthesis, facilitating the minimally invasive aortic valve surgery. It can be used in older patients with a high risk profile, and particularly if concomitant surgical procedures are planned. Finally, sutureless valve is a future without suture. Thank you.
Thank you very much. Do we have Azar to come to the stage? Great. Are you able to pop your camera on just so that we know that you're there?
Yes, now.
Excellent. Thank you very much. So I know we've had some questions between us as a panel, and we're all curious, similar to the previous presentations, about patient selection here. you did this as a retrospective review. So in terms of your usual practice, how are you choosing which of these patients receive which valve? And also perhaps, is there another cohort you haven't told us about who are not having the mini stenotomy? How does that work?
So basically, first of all, choosing between the mini sternotomy and choosing between the conventional median sternotomy is usually related to the regular prerequisites like the patty habitus and the weight of the patient and the possibility of easily having the mini sternotomy option for the patient, being safe for the patient and without having any problem with the root and the aorta itself. This is regarding the mini sternotomy and regarding for having a safe cannulation and going on the bypass for the patient. This is regarding the mini sternotomy and the median sternotomy conventionally. Regarding the choice of the patient, usually we go for as we mentioned before, regarding the Percival valve, usually the Percival valve come in the gray zone between the perimount Edward manganese and the TAVI option. So most probably, usually, most of these patients are patients who are being reviewed by the TAVI option. So we have the option of either going for the Percival valve or going for perimount Edward manganese. So most of these patients are above the age of 70. Actually, to be honest, we don't have a specific selection criteria for going for Percival valve. So the single surgeon experience here is according to Mr. Bagay, and he is one of the tutors for the Percival valve, and he doesn't have a specific selective criteria, but the first of all, that the patient who has been abandoned from the TAVI protocol, and then the patient who was having a low ejection fraction and who doesn't need to have a longer long bypass time or longer cross clamp time. So we usually go for Percival, and again, we don't use the patient of above 60 or 65 years old. We usually go between 70 to 75 years old.
Okay, thank you. Any other questions on Slido, Omar?
No, it was there were all questions regarding patient choice. Yeah.
I think Neil's having some audio difficulties, but do you have a question, please?
Yeah, I typed it onto Slido actually. So you didn't find a difference in pacemaker rate, but even though the reduced cross-clamp time, bypass time, did you find any clinical differences? I didn't see any.
So basically, the point is related to the patient choice from the preference, from the first of all, because basically we don't have a difference at the statistical difference between both groups. But going into the correct number, we were having two of the three patients who were going for Percival valve already starting with left bundle branch block, and with taking into consideration that the group going for Percival valve usually elder group, so possibility of going for heart block usually is higher than the patient of young age group of the perimount manganese. That's why I think we still need to go more for the number of the patient. We just have 72 patients over the last 7 years, and I think if we increase the number over 10, 12, 13 years, you are going to find that difference between the permanent pacemaker risk between the Percival valve and the perimount manganese, because I think it is still 3 over 72 is still not that big number. But if we go through the series of the perimount manganese, we'll find that a need for going for pacemaker is higher. But I agree with you, but it's still too short to tell about the rate of the pacemaker for the Percival valve.
But with 72 patients, you didn't show any clinical differences, but it's a vastly more expensive valve. So where do you think the advantage is?
So I think the advantage is still, as we are saying, we are trying to make it selective more for the patient who TAVI went down, like the TAVI cancel it, and the patient doesn't go for TAVI, low ejection fraction, and the patient, we need to just to go quicker for cross clamp time, and that's it. That I think this may be the main difference. But I think that it's still too early to tell about the Percival valve. I think we still need more than 10, 12 years, maybe reaching up to 15 years to tell about the permanent results for long term for the Percival valve.
That sounds like a great point to end that conversation on, and we'll move on to our next presentation, which is pushing the boundaries and advanced techniques using sutureless aortic valves in complex cases with Ian Cummings. Thank you.
Thank you.
Moderators, ladies and gentlemen, my name is Ian Cummings. and myself and co-authors would like to thank the SECS for giving us this opportunity to share our work. I have no conflicts of interest. Coinciding with the TAVI era, Percival and Intuitive valves provide a surgical alternative in a space increasingly occupied by transcatheter technology, especially in medium and high-risk patients. Notwithstanding technical considerations for the 4 available Percival valves, this technology is well established since the early European trials and has broad applications. Early studies showed that in AVR with concomitant procedures, Percival valve implantation offered an additional surgical strategy for the high-risk patients, with the benefit of shorter cross-clamp and cardiopulmonary bypass time, which is particularly advantageous in technically challenging cases. If one was to ask which patients benefit from Percival valve implantation, I would simply say any patient in whose outcome is improved with a shorter operation. The contraindications to implantation are mainly technical. However, for the purposes of this presentation, I'd like to highlight the fact that endocarditis is considered a contraindication, and an implantation in this setting is considered an off-label application. With more groups adopting this technology and publishing their results, we're now getting to the era where we can critically analyze the data coming through registries and cohort studies. Recent meta-analyses and midterm results so far look very promising in terms of hemodynamic and clinical performance of the valve. They have proven to not only demonstrate comparable results with conventional sutured biological valves, particularly helpful in minimally invasive surgery, and also in patients with intermediate to high surgical risk. The true validation of this new generation technology will come with comparisons in the long term to the gold standard conventional stented bioprosthesis. Our small series describes the short-term outcomes using sutureless aortic valve replacements for technically challenging aortic root reconstructions, including reoperations, failing homografts, and infective endocarditis. We retrospectively analyzed clinical and echo data from November 2014 to October 2018. Primary outcomes included in-hospital and post-discharge mortality, strokes, reoperation, reinfection, and paravalvular regurgitation. 19 out of the 21 patients had underwent reoperation, with 8 being for prosthetic valve endocarditis and 11 for structural valve degeneration. 2 of the patients with first-time aortic valve replacements for infective endocarditis. The median Euroscore 2 was 5. Regarding outcomes, there was 1 hospital death with late endocarditis. There was 1 reoperation for bleeding and 2 post-operative strokes. 1 patient required a permanent pacemaker. Mean transvalvular mean gradient at discharge was 16.4 millimeters in our patients. The average hospital length of stay was 18 days. 2 patients required late aortic valve reintervention. None of the infective endocarditis patients became reinfected. We would like to share with the audience a particularly challenging case of a 51-year-old gentleman who was 142 kilos in weight. He had a history of very aggressive Staph aureus endocarditis. The echocardiogram showed aortic valve vegetations with a fistula to the right atrium. He was transferred in pulmonary edema and underwent emergency surgery. We performed bicable cannulation, antegrade and retrograde cardioplegia were instilled. Vegetations were seen on the aortic valve with a posterior annulus cavity abscess. There was a fistula into the right atrium. The tricuspid valve was detached, the fistula debrided and closed. An aortic root patch was fashioned. It was a small neoannulus, which allowed for implantation of a medium-sized bioprosthesis. He was extubated the following day and post-operatively required a permanent pacemaker. Our series has shown the clinical outcomes are satisfactory for this high-risk population in the context of complex aortic surgery. We're broadening the indications for Percival valve also to include root enlargement techniques, which will hopefully have the potential for valve-in-valve bioprosthetic implantation. As this technology becomes more established as part of the surgical armamentarium, we look forward to the long-term results from randomized controlled trials. It will be these trials that finally validate this technology. Thank you very much for your attention.
Thank you very much for your presentation. We are running a little bit behind, so if we're going to restrict our questions to Slido for the next couple of presentations. So questions from the audience, if you have any. Otherwise, we will move on just so that we can catch up. Okay, we will move on to the next presentation, which is minimally invasive aortic valve replacement using a single incision approach to right mini thoracotomy with Java and Seth.
Dear colleagues, dear chair committee, my name is Darren Seth, and it is a great pleasure to present on behalf of my previous mentor, Professor Klokochownik, our early results in 203 patients operated by minimally invasive aortic valve replacement using sutureless bioprosthesis through right mini thoracotomy and completely central cannulation. We have only one conflict of interest to disclose, which is commercial due to the proctorship. To date, there are many studies already published on this topic, starting with 1993, when aortic valve replacement through right thoracotomy was introduced in order to reduce surgical trauma and improve cosmetic results, followed by publication of Drs. Cosgrove and Sebic from Cleveland Clinic in 1996, who presented their first mini-invasive AVR using right parasternal incision. The same year it was performed in Ljubljana Center, and this year it will be 25th anniversary. Still, most of minimal invasive aortic valve replacement is being performed through mini sternotomy, while right mini thoracotomy is being used together with femoral cannulation. Recently, we have published our early results in Journal of Cardiac Surgery, and we have enrolled 203 patients consecutively in the study period between March 2016 and June 2018. Our aim was to evaluate safety and early post-operative results of our approach. Primary endpoints were 30-day and 4-month mortality, and secondary endpoints were cross-cleft and bypass time, surgery duration, post-operative echo, and early complications. This table demonstrates preoperative clinical and demographic characteristics of our patients. We have included all patients that were eligible for AVR with valve prosthesis, and for the study we have excluded combined surgical procedures. It is also visible that most of the patients in this cohort were elderly and high risk, with around 31% of them older than 80 years. Here is our surgical technique. So we are using a standard approach with the right anterior mini thoracotomy with incision performed in second intercostal space. Patient is intubated with double lumen tube in order to enable lung isolation. Cannulation is completely central, both arterial and venous. And aortic cross clamp is performed through the same incision, and we are using a single shot of the Lvot antibradycardia. Here you can see valve sizing and sutureless valve deployment, which is being performed in a standard fashion over the 3 guiding sutures. Here are our intraoperative results. We had actually excellent cross-clamp and bypass time of 35 and 60.5 minutes. Duration of surgery was around 2 hours and 15 minutes, and our implant success rate was 100%. We were also glad to see that we were able to use large and X-large sized valve in even around 72% of patients, and we had conversion to mini sternotomy only 1% and to mini sternotomy in only 1% of patients. Our early postoperative results were also excellent, showing inotropic support of 6.2 hours and mechanical ventilation duration of around 7.4 hours. Patients had minimal chest drainage and minimal blood products transfusion, and we have found very good echocardiographic and hemodynamic outcomes. Our 30-day mortality was only 1%, and 4-month mortality was also 1%. We have not discharged any patient with moderate or severe parallel leak, although we have noted 1 patient with moderate parallel leak during the 4-month follow-up. We had re-expiration for bleeding in only 2% of patients. In conclusion, mini AVR approach with a sutureless perceval valve via the right mini thoracotomy and complete central cannulation is an effective and safe procedure in experienced hands and demonstrates excellent early clinical and hemodynamic outcomes. this approach can be particularly valuable in high-risk and elderly patients, and the use of sutureless aortic valve allowed shorter cross-clip and bypass time. Still, further studies are required with long-term data to determine the role and durability of the sutureless aortic valve replacement. Thank you all for your attention.
Up here, do we have any questions from the audience, please?
No, we haven't got any questions on Slido. Are we bringing both speakers in for the previous presentations? Okay, so I think it's only Davron who's with us. Thank you, Davron, for it's an excellent series, I must say. The results are very impressive. However, I've got a philosophical question. You've got a very short cross clamp and bypass times, and I understand, but this hasn't, in any of the series that we've seen presented here, hasn't interpreted into actual clinical benefits. So why don't you not use a bypass at all? Why don't you use a TAVI? Why is a sutureless valve better than a TAVI?
Well, thank you for the question. I think so. Most of these patients were also considered for TAVI because they were high risk. And I think that we think actually the biggest advantage is that with a surgical approach, we are able to provide full debridement of annulus to completely debride the calcified material, and in this order to prevent paravalvular leak and to deploy the valve safely. So that's the main advantage in comparison with TAVI, which of course doesn't allow full debridement of annulus. I think actually with right intraoperative approach, these patients do recover very well. They do mobilize earlier. They don't need 3 months of restraint for activity because there's no breastbone cut. And basically, average length of stay in this study, we expected to be lower. It was not because we had a few patients that actually stayed in the hospital due to post-operative stroke, so they were not repatriated. One of the patients was actually 51 days in the hospital. So basically, when we would look at the data without these few patients, we would have even shorter hospital stay. Also, they had less pain, they had less chest drainage, less requirements for back products, and with short cross-clamp time, it seemed that they mobilized better.
Okay, so yeah, I think there is a theoretical benefit in excising the leaflets. However, if you look at the new generation TAVI valves, you'll find that the rates of both paravalvular leaks, the rates of pacemaker insertion, are very similar to the rates that we're seeing with sutureless valves, and they go home on day 2. So I understand the theoretical benefit, but I think with the modern technology TAVI valves, I don't think that benefit will be there for long.
I think
yes, agreed. There was an important trial.
Sorry to interrupt there. I'm sure this is a discussion that we will continue and will absolutely carry on, but we're going to move things on in the interest of time so that we can give all our presenters a little bit of the time they deserve. So the next presentation, please, is 10-year results after implementation of an aortic valve repair program.
Hi, I'm Anas. I'm one of the consultant cardiac surgeons at Nottingham University Hospitals. I'll be giving this talk on behalf of Dr. Pettinari group at Genk, Belgium. This topic was part of my fellowship in Belgium a couple of years ago. So over the last couple of decades, there were remarkable advances in aortic valve repair. Large centers showed very good long-term results. And thanks to developing a standard assessment of the aortic valve repair, many centers adopted this procedure. And we aim to look at the Genk experience with this procedure. So in this paper of Budwani et al. From Al-Khoury group, which looked at a repair-oriented classification of aortic regurgitation, published in 2009, showed good long-term results. And what is more important in this paper is that it developed a standard approach to the to aortic regurgitation with a functional classification, which was inspired from mitral valve Carpentier classification. So if we look, for instance, at this TOE, there is a prolapse of the right coronary cusp, and this would be a type 2 cusp prolapse, and it could be addressed in a number of ways, including plication or triangle resection. So the program of aortic valve repair in Genk in Belgium was started with a proctorship from Prof. El Khoury, and the program was established in a collaborative way. And the outcomes we looked at included survival, recurrence of aortic regurgitation, and reoperation rates. So as you can see there, this is a relatively young population of patients. And the mean ascending aorta diameter was about 50 millimeters, and more than 85% of patients had either moderate and or severe aortic regurgitation. Valve sparing procedure and the various valve repair approaches were used, obviously including the David aortic valve repair, Cosgrove, annuloplasty. So in this video of bicuspid aortic valve repair, aortic leaflet is plicated. Then the graft size is measured from the nadir to the highest commissural point. Valsalva graft was secured using pledgeted sutures in the undersurface of the aortic valve and the LVFT. The valve is then resuspended and secured to the graft along with the rim of the aorta. And the leaflets are tested again, and further leaflet plication is performed with very good outcome in this procedure. And we looked at the post-operative outcomes, which were quite good. In hospital, mortality was 2%, and the overall survival was actually very good in this cohort of patients, exceeding 85% at 10 years. And 78% of patients had either no, trivial, or mild aortic regurgitation, and 8% had moderate AR, and the remainder had moderate to severe aortic regurgitation. The reoperation rate, as you can see there, was very low in this cohort of patients. So in conclusion, aortic valve repair program is reproducible in smaller centers, following obviously adequate proctorship and partnership. Is also essential to have continuous governance to ensure safe delivery of this procedure, which clearly has benefits, especially in younger cohort of patients. Thank you very much.
Thank you very much again for that excellent presentation. I do apologise that we don't have time for questions at the moment, but we're very keen to make sure we crack on and get to our keynote speaker. We will try, if we can, to come back at the end to any questions specifically relating to the last two presentations. So thank you very much for that. And what we will do now is move on to our final abstract presentation, which is long-term outcomes of sutureless and rapid deployment aortic valve replacement, a systematic review and meta-analysis.
Hello, my name is Michael Williams, and I'm a cardiothoracic registrar at Royal Prince Alfred Hospital in Sydney, Australia. And today I'll be speaking about the long-term outcomes of sutureless and rapid deployment aortic valve replacement, a systematic review and meta-analysis. The treatment of aortic valve disease is the most common valvular surgery in industrialized nations. As transcatheter aortic valve replacement has become more established, Newer surgical prostheses have been developed, such as the sutureless and rapid deployment aortic valve replacement. There is a plethora of literature that has evaluated the short-term safety and efficacy of these valves. However, long-term data is lacking. The purpose of this review is to assess long-term outcomes, including safety, clinical efficacy, and complications of sutureless and rapid deployment aortic valve replacement. For the methods of this study, 6 electronic databases were searched from inception to December 2019. The primary outcome was overall survival and hemodynamic performance at 5 years post-valve implantation. Secondary outcomes included late and short-term follow-up incident rates of post-operative outcomes, including neurological events, permanent pacemaker insertion, severe paravalvular leakage, and operative details, including cardiopulmonary bypass and cross-clamp times. I-squared values were used to assess heterogeneity between studies, and a value of greater than 50% was considered significant. As you can see here in the Prisma flowchart, just over 1,200 articles were identified, and after duplicates removed, we were left with 829 which underwent title and abstract screening. After removal of irrelevant studies, 47 underwent full text review, and eventually 4 met inclusion criteria. So across these 4 studies, there was just under 2,000 patients. There were 2 studies that actually fit the selection criteria. However, they were excluded due to focusing on the 3F enable valve, which is no longer commercially available. From the 4 included studies, just over 1,200 patients received the Percival valve, and just under 800 patients received the Edwards intuitive valve. Weighted pool age of these patients was 76.2 years, and just over 40% of the patients were male. At 5-year follow-up, survival was 84.2%, as seen here in figure 2 from aggregated survival curves. Mean pressure gradient range at 5 years was 8.8 to 13.6 millimeters of mercury. Peak pressure gradient range at 5 years was 18.9 to 21.1 millimeters of mercury. And effective orifice area range at 5 years was 1.5 to 1.8 centimeters squared. At late follow-up, overall mortality and cardiac-related mortality were 8.9% and 3.7% respectively. Late neurological events were 4.8%. There were 25 total cases of endocarditis. Permanent pacemaker insertion and valve explantation rates were 8.2% and 2.3% respectively. Severe paravalvular leakage only had a rate of 1.5%. There were no reported valve thromboses and only 8 total cases of structural valve deterioration reported at late follow-up. In terms of early follow-up results, weighted pooled mortality was 1.4%. Rates of early neurological events and major bleeding were 2.7% and 2.4% respectively. There were only 2 reported cases of endocarditis in 1 study, and rates of valve explantation were 1.1%. A weighted pool estimate of PPM insertion at early follow-up was 6%, and severe paravalvular leakage rate of 0.7%. There were no reported valve thromboses or structural valve deterioration at early follow-up. In conclusion, the sutureless and rapid deployment aortic valve replacement provides a safe and reliable option alongside established therapies in the armamentarium for treatment of aortic stenosis. Long-term overall survival post-sutureless and rapid deployment AVR has been proven to be acceptable. Safety and durability of these sutureless and rapid deployment valves are also acceptable, with low complication rates and good long-term hemodynamic outcomes. Further evidence, such as randomized control trials, are required to further assess the clinical outcomes of these valves against other established treatment options currently available. Thank you for listening.
Hi, thanks, Michael. That was an excellent review of the literature. In the interest of time, I'm afraid, Michael, we're going to have to proceed because we're really running quite late. And it gives me great pleasure on behalf of SCTS and the British Heart Valve Society to invite Professor Raimondo Ascione, who's going to give the keynote speak for this session on prototype development, bench testing, short-term feasibility study of a new polymeric heart valve called the Polyvalve. Raimondo, welcome.
Hello, everybody. I will wait to, after the presentation, we can hopefully have a chat. Thank you.
Okay.
Hello, everybody. It's Raimondo Ascione from Bristol, UK. And it is a real pleasure and a privilege to present at the SCTS 2021 the data we have on the development and testing of a new polymeric heart valve. This is a very strong partnership between the University of Bristol and University of Cambridge, with myself being the clinical lead and Professor Jeff Mogridge being the biomaterial science lead from the University of Cambridge. The background to this work is what we see in our daily activity. We have a geriatric population that is spreading significantly, with a strong prediction that by 2050, we will have 85 million of patients. We know how dominant is, for example, the incidence of aortic stenosis in this population. At the same time, right now, it appears that we have roughly 35 million of patients worldwide affected by rheumatic valvular disease. And the strong prediction is that by 2050, there will be a need for valve replacement procedure of 4 to 5 times higher than now. So in this element of background, it's also important to appreciate that while we have effective valves, artificial valves being used at the moment, it is also fair to say that they have a limitation, in particular poor durability for a biological valve, regardless of whether they are surgical or percutaneous, due to failure, thrombosis, calcification, and endocarditis. In addition, we know that mechanical valves have a poor biocompatibility due to mandatory need for anticoagulation and the association of this problem with the 3 to 4% thromboembolic hemorrhagic event per year in this patient. So we really wanted to take the good things of the current valve and therefore hopefully design a new valve that has long durability and very good biocompatibility. And what you see here is basically the polymeric heart valve we have produced after roughly 5 years of intense work. And this is the J6 prototype, which I will present the data about during this presentation, which is the latest version, which we reached roughly 2 years ago, and that is what we feel, has got clinical potential in terms of performance that we have seen. So initially in our concept, we wanted to eventually include an inert low porosity material. We wanted a very good biocompatibility and durability, possibly more than 25 years, and if possible, a simple manufacturing process. And so you already know, I'm sure, the complications associated with the manufacturing of current biological valve, either open device or percutaneous device. They eventually reflect integration of biological material with metal stent as well as fabrics. And of course, the background to this is kind of the maintenance of large animals at the clinical and clean standards, as well as processing these animals, getting the tissue, and then going to this large factory where effectively these valves are sutured by hand, and it appears that each one of them requires roughly 2,000 suture points. So very complicated process, which also has got the complicated quality control. In our idea, we wanted a platform technology, and we have developed this that in a nutshell include 2 obvious steps. One is basically the computational modeling, and the other one to follow is the manufacturing by injection molding of using commercial styrenic block copolymers, which we call SEBs. Of course, these 2 steps are not, particularly the first one, easy to get right. in our case, it's taken 5 years. But once you get it right, by including the computational modeling, all the important information that will allow a meaningful device to be produced. So then obviously it became simple. So in our case, what you can see through this painful, but at the same time pleasing kind of enterprise, we have developed several prototypes, and the latest one, the J6, is the one that you see here, which as I said, we feel is meaningful. You can see here a summary of a bit more closely look at the device. Again, the key aspect of manufacturing by injection molding, 3-leaflet, fully polymeric valve, no presence of metal, no presence of fabric, and the use of a slightly different two type of block copolymers. We have been using ZEBS 29 for the ring, which is this area, and the ZEBS 20 for the leaflet. I'm making it very simple, but it's been much more complicated than that. Effectively, we want to achieve a valve that is fully dynamic, like you can see in this video. You should be able to do these things to this valve, so you can squeeze and compress the valve, but there is an element of flexibility and shape memory, so the valve is returning to the normal shape at the end of this process. And so once that is made and the computational modeling is finalized, so then the molding became relatively simple. And here you can see that we have been able to make quite few of the 17, and 19, and 21 millimeter valve, because we've been focusing mostly in the first stage on the low or small annulus. But our aim is to produce a full range going from 15 to 30 millimeter valve, and that is a process that once the modeling is right, then is relatively simple. There is this option because of the type of material used that we can do heparin coating, which we have done and have evaluated many of our valves following heparin coating, but we have also done tests on valves that have not been subjected to heparin coating. And I will show to you one of the slides later on to just highlight that there is no difference. So the device with or without heparin coating seems to be at the bench testing very biocompatible. One critical key feature we want to achieve in the valve is the anisotropic structure. So this is just first of all to appreciate that in these polymers there are some nano cylinders. So we wanted the process of manufacturing through which we can actually influence the positioning and alignment of these nanopolymers. And we've been able to achieve that through a controlled manufacturing process that involves paying attention to key aspects like, for example, injection point, injection rate, temperature, as well as the sequence of injections, for example, first the ring and then the leaflet. Here you see a schematic. The blue dot is the injection point at the end of the process selected for the J6 prototype. And these segments represent these nano cylinders. And we've been taking X-rays of the valves following lots of injections until we achieved consistency in achieving these nano cylinders being aligned horizontally more close to the free margin of the leaflet. This obviously is a representation of a leaflet, and more toward the middle, these were aligned more vertically, as you can see, and more toward the annulus in sections or ring in sections, more crosswise. We have seen that, and we feel that this structure is associated with better performance and durability of the valve. And by the way, this is what we also see in terms of alignment between collagen and elastin fibers in a native valve leaflet. Of course, the focus then moved on to the performance, and we done lots of durability testing on our final prototype J6. And what you see here eventually is all our durability testing over time, but really the focus is this bar, the J6 bar. So at some stage, the manufacturing was so good that we made lots of 19 and 21 millimeter valve, and they in groups were sent for different type of evaluations, biocompatibility, durability, aerodynamic test performance, extra vivo refinement of implant here in Bristol. And eventually, we selected randomly 4 of our manufactured valves, so 221 and 219 millimeter, and we put them into the accelerated heart valve durability test, which is what any regulatory body wants you to see, to do and to see. We did this at 13 hertz, which is quite challenging shear stress for the valve at a arterial systolic pressure. So for not cherry-picked valve were included in the accelerated test. And what you see is the performance. 1.2 billion cycles reached on average in this paper that we published a few months ago, which is equivalent to more than 30 years of in vivo lifespan, which is really the point. And of course, we have here listed, the one by one valve for these 4 valves. And important to appreciate that one of these 4 valves is still going, has not failed, which is all very reassuring, particularly when considering that we have made this valve as a research group in a research lab, not into a GMP type of facility, which is what you would expect when it's about to reaching bedside implant. So this is all very reassuring. Here you see, importantly, the valve motion and dynamics into the accelerated tester. And I would like to draw your attention to the fact that this is a wall dynamic device. You can see how the post of the valve move in synergy with the leaflet, and we feel that this synergy is critical for the aerodynamic performance as well as the durability that we have measured. Of course, we then measured the aerodynamic performance on these 4 same valves while they were aging and fatiguing into the accelerated test. Every 100 millions we would stop, take them out, subject them to aerodynamic performance of what you see in these variables: effective orifice area, regurgitant fraction, and means gradient, so that we could check the same valves over time. Is there anything changing in the performance as we age and fatigue this valve? And you can see here the graphic in relation to the effective orifice area did not change over time. And most of all, in red are the 19 millimeter, in blue are the 21 millimeter. Most of all, as I said, at any of these time points, the performance was better than the minimum requirement imposed by the ISO standards. In this table, you see the summary of the valve implanted and tested in terms of average effective orifice area, regurgitant, and mean gradient for the 19 millimeter, for the 21 millimeter. Here you see 2 valves that we selected that are, in our mind, the best-in-class biological valve, 21 millimeters. So you can compare those numbers with this, and you can see that there is no difference. So our valve in terms of aerodynamic performance is as good as a biological best-in-class valve, perimount biological valve. We also, based on FDA formal feedback, performed on 2 of these valves, aged the valve, testing 18 months after packing them, sterilizing them, and keeping them on the shelf, because this is one of the safety evaluation that is necessary. And again, you can see that after real aging, the valve performance did not change compared with the newly made valve, which is all very reassuring. This slide is a little bit of a repetition of the previous one, but eventually allow you to see the 3K variables of the aerodynamic performance, where you actually see the red cycles are the 19 millimeter, the open kind of black cycles are the 21 millimeter, and the black square are the 2 biological perimount valve. What this is telling you really is that the 21 millimeter performed as good as the perimount for all of these evaluations, and at any time point they were doing better than the minimum requirement by the ISO standards. We also focused on the biocompatibility testing, which is important. And again, there are established methodologies to use to satisfy regulatory bodies for bench testing of a new, possibly thrombogenic device. What you can do is to use the body-mount perfusion chamber system. So eventually there are little plexiglass chambers through which it's possible to flow by peristaltic pump blood taken from healthy donors, and you can do that flow at a low or high share rate and for as many hours or days is possible. And eventually you put into this little chamber the thrombus or the test material, in our case strips of the valve, and these are eventually the pictures of the heparin coated several strips of several valves with no presence of thrombus, which is all very reassuring. Only, for example, in this one, some little clumps of red blood cells and fibrin, which is, as I said, all very reassuring. We have repeated the same testing on strips of valve not heparin coated, again with no evidence of thrombus formation, which is, as I said, all very reassuring. So one other things we have done was to evaluate the MRI compatibility. As you know, often we are asked, can we actually do an MRI on somebody with a metal valve? It's not a straightforward story. Our valve is MRI compatible. You can see these are a porcine heart with the valve implanted in aortic and mitral position. And you can easily see the valve, the details of the morphology without basically artifact. We also know that the valve is not visible on chest X-ray. And we also know that it does not produce noise when in vivo functioning. Obviously, we did surgical implantations at the Transitional Biomedical Research Center at the University of Bristol. And we had to develop first a model of ship cardiac surgery, which was through a thoracotomy, which you can see here. Eventually, then we could, manage well, the heart-lung machine, the right flow, the right maintenance, and implant. We elected to do aortic valve implant, which is much more complicated because you need a large animal to be able to implant a 19mm valve, for example, which is what you see here. So the valve were implanted according to established surgical technique. This is the valve just before sitting it on the annulus, and this is after eventually stitching them before closing the aorta. This study is summarized in this final slide, which is eventually an in vivo feasibility short-term study. We wanted to answer for this study, we studied simple questions. Can we actually stitch this valve in vivo? Will this valve open and close? Will it have a transvalvular or perivalvular cross, leaks? Will the valve have a meaningful, clinical meaningful aerodynamic performance 1 to 2 hours after weaning heart-lung machine? And will there be any gross clotting on the valve if we don't use anticoagulation? So the study has confirmed all of those things. So we could stitch all the 3 valves, with no problems. These are some pictures of the transverse view of the aortic valve at roughly 1.5 hour after weaning heart-lung machine, with the valve opening, closing well, with no diastolic leaks, as you can see through the valve all around it. This is the same valve into a longitudinal view. The same valve, this is a peak gradient measured on this. These are 19mm J6 prototype, which is 24mm, and the average was 22, which is in keeping with what we had already measured at the bench testing. And of course, one of the key aspects of doing this study is that we had the green light to then proceed to the long-term preclinical study that is now ongoing. So in summary, therefore, I can conclude and just summarize that we have a new polymeric heart valve that has exceeded markedly the ISO standards for bench testing and valve durability. It's got an aerodynamic performance that is comparable with one of the best-in-class biological device. And we have passed the test of feasibility short-term in vivo testing with very good data, and therefore we actually after that did a formal pre-submission to the FDA, received the formal feedback on the design of the long-term study, which we have now started. So of course, this study has been possible thanks to the assembling of a rather unique multidisciplinary team that has been working on this project. These are key colleagues and also inventors on this project. So myself as a clinical lead, Professor Jeff Mogridge, that is eventually, as I said, the biomaterial science lead from Cambridge. Dr. Marta Serrani is the expert in computational modeling from Cambridge. Dr. Joanna Stasiak, again from Cambridge, leading on the manufacturing and bench testing. This is a research group, of course, and everything has been done at research kind of grade. Of course, all the preclinical implant, extra vivo and in vivo has been done at Translational Biomedical Research Center in Bristol, and therefore I would like to thank a few members of my research team, Dr. Guido Domenico Bruno, for the important help in the preclinical extra vivo in vivo implant. More recently, Dr. Ettorino Di Tommaso for the same role, and Dr. Eva Sammut, NIHR clinical cardiologist with a special interest in preclinical work as well as imaging, who has done most of the echocardiographic evaluation. This is also important for us to acknowledge the role of the British Heart Foundation And it is thanks to a major special project grant in the order of £750,000 that we have been able to do all this work, as well as a big thank to the MRC for co-funding the Translation Biomedical Research Center. And a final thank you to all of you for listening, and I will be very happy to answer any question that you might have. Thank you very much for listening.
Right.
Raimondo, that was superb.
Thank you, Norman, very much, and very pleasing. I know that in the moderators there is also Professor Jeff Mogridge, who has had a key role with his team in developing this fully UK-based valve. Hi, Jeff, nice to see you.
Can I ask? I'll start with a couple of questions.
Sure.
One, I think I probably know the answer to, but obviously this has been tried before, as you very well know. There was a polymer valve from Scotland, from Glasgow, which didn't work. But clearly manufacturing, computer modeling has improved. Well, didn't exist then. So that's one. Why did previous polymer valves fail? And the other thing is, as you know, there's another company that have started, Foldax are manufacturing the Tria valve, and they've already started implantation in man. And I wondered whether there are any major differences between that valve and your valve.
Thank you very much, Norman. I will say a few things, and then perhaps Jeff could also, contribute. You are right. There are previous, 20, 25 years ago, different type of polymers or were used and different technologies. So I think it's fair to say that in terms of durability, performance, and also manufacturing, this device is completely new, and including the type of polymers we have used, of course. And I think, what we have in terms of durability is pretty unique. And obviously, we are aware of the Foldax valve. And these two projects looks like have been happening in parallel. And they have already reached a first-in-man implant. But we know exactly what they have done. And Jeff can add a little bit. Our valve is quite different to that valve. For example, that valve does have a metal stent inside and has used polymers that in the past may have appeared to be associated with oxidation. But I would be very pleased if Jeff could indeed add a little bit more from the biomaterial point of view, please.
Yeah, so I think what you said about this being a good moment for polymers is very correct. And actually, there is a bit of a renaissance. There are several groups now developing polymeric valves. And I think that has a lot to do with the modeling and material development, as you said. So I think these things should not simply be seen as competition, but actually evidence of this being a good moment. What's unique about our approach is that we're using an anisotropic material. So it's got different stretchability in different directions, and that mimics the natural tissue, which has fibrous elements in it. So what we're aiming to do is mimic the natural valve, and that the modeling shows us that should give us improved durability. So there are differences between the different approaches. I don't think it's clear yet which will turn out to be the best, but that is our unique selling point, as it were. Raymond is also correct to say that ours is, I think, the only valve which is completely polymeric, including the whole support structure.
Right.
Yes.
Thank you, Professor. Excellent effort, and we're really looking forward to that coming on. There's been a couple of questions on from the audience, and one for myself as well. Obviously, your in vivo implantations were all surgical. Have you played with the thought of having this as a catheter-based deployment, or is this too early in the?
Yeah, Omar, thank you. Very nice questions. And what you have seen today is what we could show today, and this is obviously our open surgical device, which is the most advanced. But through the technology platform we have now created, we have, and I can only say very little, already prepared a percutaneous version, and we have produced a true prototype. And obviously we are optimizing them as we had to do over 5 years for the open valve, and is in the process. And so we can't say more because that part of the work is still ongoing and is still not protected.
Thank you.
Neil, please.
Yeah. I think it's fantastic piece of work. I'm really excited about putting one of these valves in, hopefully soon. I've asked the question before, but it's in the bicuspid annulus where it's not a nice round cylinder, and with that very flexible valve, how do you feel that the J6 will hold its shape and work?
It's a good point. And the valve we implant, like all the biological valves, have this kind of saddle type of shape and this kind of three symmetric commissure type of setting, isn't it? So we do have that problem already now. And the issue with the current valve, I don't know if it's an issue, but we feel that it is, that they are quite rigid and static. Our valve being flexible and we say dynamic has got more potential to adapt to the dynamic systodiastolic motion of the aortic annulus. And we feel that that element not only improve, hopefully, and is a contributor to the long durability, but could also enhance the element of that you're just alluding to, of obviously adapting and working with a dynamic annulus, which is obviously the hope. But of course, time will say. Clearly, we can't control for that particular point in the preclinical setting, of course, because we will not have a model that can mimic exactly the bicuspid type of scenario.
Can I just add something to that, which is that one of the attractions of the system of polymers we're using is that by varying the styrene fraction, you can vary the stiffness of the polymer. And so at the moment, we use two polymers, a stiffer one for the support structure and a more flexible one for the leaflets. And it would be perfectly possible to add a third, even stiffer polymer at the base. So we could produce a system which had a really quite rigid base, then a quite flexible support structure and even more flexible leaflet. So I think it's up for discussion as to which of those would be better for different applications, but there's certainly the opportunity to produce a more rigid base if that's required.
I think in actual fact, the surgical valve, one of the advantages of a TAVI is that with current surgical prosthesis, we make sure that the annulus conforms to the prosthesis and not vice versa. And I suspect a bit of stiffness to the base was probably
I think
turn out to be desirable. Yeah,
I think what Jeff is clearly saying that you can actually tailor. You have this opportunity to actually tailor the engineering in relation to the specific, indication. And that is something which clearly at the moment we are proving the concept. You can make a valve and it's durable. Actually, speaking about a TAVI, while, as I said, we are working also on a TAVI configuration, our really point is, and you have seen, with the durability hopefully being confirmed of more than 30 years, and with a valve size that could go from 15 to 33 millimeter, then you are starting to change completely the game, because by implanting a valve in a young patient who is 45, 50, you might have prevented, many other things in that patient lifespan, and you might even maybe start to reduce the need for TAVI if the valve is going to be durable and not requiring an implant 5, 8, or 10 years later. So that might be an additional bonus. But of course, that is only a speculation now, because we have just done preclinical work, bench testing. But the durability that we see allow us to have this type of considerations.
That's great. Well, guys, thanks a lot. That was really, really interesting. And as Neil says, we all look forward to implanting a new generation of valves in UK patients.
Thank you very much. Thank you to all of you, and thank you to the society for making the effort of coming up with this virtual meeting, which I find particularly good, and I've enjoyed participating in several sections. Thank you to all of you.
You're welcome. Thanks a lot. Bye-bye.
Thank you.